Grace is going to be joining in a few minutes, so hopefully I won't get too fast and ahead of her. I'm really happy to be here to talk a bit more about our work with the Community Information Exchange and the partnership with Community Connection and our South Georgian Bay Ontario Health Team. So Sarah Grace will be talking more about the Ontario Health Team in a few minutes, but Community Connection is an anchor partner in the South Georgian Bay Ontario Health Team. I'll try not to use acronyms. For us and other anchor partners in the team, we have the privilege to be a co-designer of this new model of care we envision for the communities in South Georgian Bay. And the term anchor partner is used purposefully in Ontario Health Teams as it describes the non-hierarchical relationships of the team. The team has worked hard to establish a foundation of genuine partnership and trust, and Community Connection is considered an equal partner with physicians, the hospital, and other organizations, which is really unique in our work in the community. So just to give you a sense for us, we're one of the 6 partners in Ontario, and a little arrow there showing where we are on the shores of beautiful Georgian Bay. So Community Connection's been around since 1969, and contrary to popular belief, I have not been there that long, but almost. We foster relationships with people and organizations to respond to social issues and inspire change. And this chart just gives you a sense of some of the work we're involved across many sectors in our region. So for more than a decade, 211 San Diego has been leading the development and design of community information exchanges. And the Community Information Exchange collective impact model aligns with the structure of Ontario Health Teams very nicely. And Sarah, Grace, and I appreciate the opportunity to speak about our journey. I just want to acknowledge our colleagues at 211 San Diego for their leadership and generosity in sharing their knowledge, tools, resources, and best practices for community information exchange model development in Canada. And the real purpose for us for the Community Information Exchange is really for that connection between social and community supports that Shelley spoke to in that chart, if you remember, is we have a unique opportunity to really develop that connection in a really positive way. So this is the image. This image shows a Community Information Exchange in a simplified form. So you can see that across the top there are to be involved in a community information exchange, you need a network of partners. And for a network partners, we have to have a shared language, a resource database, and bidirectional referrals, and a technology platform for data integration. And those 4 areas I'm going to speak to shortly, but all of those combine to provide the opportunity for community care planning and really around collaboration and cross-sector data sharing to create healthier communities. Right now in Ontario, we have a lot of health information exchanges, and they enable doctors, nurses, pharmacies, and other health providers and patients to appropriately access and share patients' vital medical information. And adding a community information exchange to this enables hospitals, health centers, and other care providers, social service providers, housing providers, maybe schools, and among other community resources to appropriately access and share data to improve care coordination and improve health outcomes for people. It's really important to note that a CIE is not a specific technology. It's not a generic one-size-fits-all solution. It's not intended to solve one issue, but is for the entire system of care. A CIE is not led by one organization, nor is it the direction dictated by the outcomes of one sector. It is not centered around institutional goals and interests. So this is a shift for all of us in the healthcare, particularly when we're an equal partner as a hospital with a lot of influence and capacity to really help guide the work. And the CIE really is developed to cultivate trust in the capacity within the community. It's to drive system change. A CIE is a community-led collaborative, and it's designed to uplift communities and those populations who experience disparities and inequities. And equity is a core tenet of a community information exchange. Now, how we kind of got on this journey I'm going to talk to. So there's a powerful body of evidence that shows that poverty puts patients at higher risk for cardiovascular disease, diabetes, depression. Children in low-income families are at higher risk of low birth weight, mental health problems, asthma, malnutrition, injuries, and hospitalization. And we did some work a few years ago, actually it was with Karen, around the poverty screening tool being developed by the Centre for Effective Practice and the Ontario College of Family Physicians. The screening tool was for primary care to use key questions to assess their patients' living situations, understand their current benefits, and include links to key government and community resources to support the positive interventions. And the goal then was for physicians to ask the questions, educate the patient, and then intervene and connect. You'll see 211 is one of the primary links on these screening tools. These are really multiple page tools, so I'm just put a little snippet here for you to get a visual of it. But in most cases, physicians don't have time to spend to do this education, the intervening, and connection. So in South Georgian Bay, with the work here, our primary care did adopt the screening tool, and instead of taking time to assess the patient's living situations and that, they receive patient's consent and send a referral form to Community Connection for one of our navigators to contact the patient. The visual on the right is kind of the process we developed. So over time, we developed an outcome report on the results of our intervention, and the report is faxed back to the referring clinician, and it's scanned into the patient's chart. So this process, these steps of 1 to 5, may take a long time. In some cases, our navigators are following up for many weeks on patients, particularly those in really vulnerable or complex situations. And we close that report and send it back, all by fax right now. So this referral partnership has increased to 10 family health teams, 3 hospitals, and 3 regional paramedic services. And we're able to connect about 50% of these patients to additional services and supports. And in Simcoe County, particularly, we're able to demonstrate that a reduction in repeat calls to 911 that are not emergency. So we're having some really good measures and some good impact on folks. However, closed-loop referrals and faxing, we have good patient outcomes, but workflow disruption. So our current technical infrastructure supports a high-volume inbound contact center. Our current tools have limited ability to structure adequate case notes that are needed to support follow-up activities and case coordination. This technology limits the ability to effectively schedule the volume of outbound calls required for closed-loop referrals. Privacy and security protocols require extra admin steps, and we've created lots of workarounds requiring cut and paste steps and administration burden. And as a result, we have poor workflow and reduced capacity because we'd really want to expand closed-loop referrals with other partners, and we're really limited on our ability to do that within the current environment. So back in 2019, we were able to get some funding through a federal project to contract a digital innovation solution company to help us define our business requirements. Like, what the heck did we really need to solve all these problems we were having? And it was really focused on the requirements that we needed for digital technology that would streamline our workflow. Just in Community Connections office is what we were focused on back then. We wanted to be able to enable that end-to-end referral management, notification and intake management, scheduling tools for outbound calls. I mean, we have so many referrals that multiple navigators are having to make our follow-up calls with patients they haven't talked to before. So really important that our data and our tools can help us effectively do that. We want to have more enhanced data collection and reporting and dashboards for managing the program overall. So we were able to define the business requirements, and then later that year we were successful in receiving funding through a collaborative project funded by the United Way Simcoe Muskoka to develop this product. This digital platform was what we were calling it, and this is where our digital journey actually began. Over time, though, we identified the need to develop new processes and tools used by our community navigators to improve outcomes for inquirers and patients. So vulnerable is a term applied to many populations. It could be racial or ethnic minorities, children, pregnant women, elderly people, prisoners, migrants, refugees, people who are homeless, people who use drugs, and people who have medical conditions like dementia, acquired brain injury, autism. And vulnerable people are more likely to be impacted by trauma and shame. And so we're really, in our shop, developed some tools to really embrace our trauma-informed principles, just to be aware of the prevalence of trauma and how common it is for all people, and recognizing the signs of traumatic impact and how survival stances may show up in people that we're serving. And one of our common challenges are that we'll do a follow-up call and the patient still hasn't followed up with the referrals we gave them, or they decided that they didn't need to do that anymore. So it's really just understanding and being engaged and taking steps that avoid re-traumatizing people. For example, a senior who's struggling to make ends meet, and we've convinced them now that they can access a food program in their community, we may offer to have a three-way call and connect them to the program that offers that food program, rather than just giving out a phone number where they have to tell their story again. So just starting to change, or we have changed how we process various typical ways we answer our calls, but just adding in these elements. We've also included these stage of change assessments to help guide conversations, to really figure out where that person is in their stage of change and how can we determine what barriers there are or opportunities for that individual. And the focus for us is not to convince the person to change their behavior, but to help them move along the stages of change and embrace the services that are available to them. And then the practice of empowerment conversation skills at the right time are really important. And we're really able to show how effective these activities are. And during these activities, we collect detailed data, which is helpful to support the households that are in complex situations where multiple follow-up calls are needed. And the data that we collect is also useful for their healthcare provider to understand their patient's living situation. The other elements, other additional challenges we've identified with the process is really our traditional referral process. Right now, the client carries all the weight of the next steps and access. It's not trauma-informed, so clients have to describe their situation repeatedly to different people. The lack of ownership, the client easily falls through the cracks. We can give them, if they don't follow up and we can't get a hold of them, we're not able to help them. Organizations that we're referring to or receiving these referrals start from scratch, so the benefit of the details we've already learned are determined by our community navigators. And then our anonymous service delivery, it relies solely on the client to self-report, and clients in crisis or risk may not be good historians. One example that happened to us was we had a family that had a very tragic situation happen, and when our team looked at what happened and how we ultimately failed that family, it turned out that family had called 7 times to 211. Each call handled effectively and appropriately, but because our navigators couldn't see the connection between all the calls, we ultimately failed that family. So that lack of data, it wasn't our service that wasn't good. It was really just that missing piece of how we collect and use the data to better serve people. And so we can't right now, with anonymous service delivery, can't view that client history or their status changes. And it really limits that holistic understanding of their situation, like that family I just spoke to. And it also limits our ability to support case coordination or goals and prevention work as we're moving people along that stages of change process. One of our solutions was to develop a new longitudinal record. And right now we're just in the final stages of testing. I feel like I've been saying that for months. But we received funding in 2020 through United Way, Centred Canada, through the Emergency Community Support Fund. And through the funding, we're able to develop this new longitudinal record. And it really will connect all our call reports for each client so that we can then see if they've called before, how did we help them before, those kinds of things. It guides more detailed data collection, so we can be very specific and have more streamlined and more workflow processes on the data collection side, and have more drop-down lists and pick lists, so we can really be more improve our data collection and standardizing our data collection. This tool connects with our existing legacy systems, so the current technology we're using now, and it will also connect with the end-to-end referral management system that we're currently building as well. So just one of the other tools being developed by 211 San Diego is called a comprehensive social continuum assessment, formerly known as a risk rating scale. And this has been a really exciting area of our work to really dive into and understand the value of this tool in our information and referral environment. It's really to serve as a common language to understand the complexity of social influences on individuals. And it can also be used with other approaches. If we're looking at advancing racial equity, for example, there's different ways we can use this tool as we're trying to move along our journey of improving our equitable services. The goal of this tool is to holistically capture the comprehensive needs of an individual and track the change over time. The next slide gives you a little visual of what this tool looks like. So it really is an assessment tool that it determines the immediacy of a client's need along the 14 domains at the top in the blue. And it establishes a baseline risk to measure that change over time. And this example where the red arrow is pointing is using housing and home safety. So for example, if a caller or a referral came in and it was someone at risk of housing, we would ask specific questions, and then the tool would determine what level of risk is that person. Are they in crisis or are they vulnerable? And it actually connects to our taxonomy in our database of the services available for that risk assessment. So it's really smart in that it's effectively tied to the services and that we would refer them to. If a navigator was to use the assessment of all 14 domains, we understand it would take about 10 minutes or so. And the value of choosing one or more of these assessments is that when we do a follow-up call, we do the assessment again, and we can see if that individual has moved from crisis to critical. Were they safe and they're now vulnerable? So we can actually measure the impact of our service and the connection to other services on their well-being on this scale. And earlier this year, we received additional funding through a federal project to purchase the tools, materials and questions, responses, the scoring and the algorithm, and guidance from the team at 211 San Diego. So right now we are working towards the business requirements that will include this assessment tool in that call report I spoke to earlier. It's really exciting work, and I think for our United Way partners, this kind of tool, for example, every 211 could maybe assess callers for a month on income or transportation for a certain region and produce that data in real time. I think it has really powerful opportunity to really get a picture of the needs of our communities and the different types of impacts or social risks that families are coping with. So the big piece of work that's underway right now as part of this community information exchange is the development of a longitudinal record that we'll use for coordinated care planning. This is just an example or a sample of a part of one from San Diego. And it's really comprised of data from multiple partners. So we envision in our Ontario Health team, various partners will contribute data on the same client into this longitudinal record. The data collected by different service providers stays in their system. No one's changing technology, but we're really just using the Community Information Exchange to collect the data in a single longitudinal record of all the services in the community for each patient. This record is stored in our CIE's Azure cloud, and partners' credentials would allow tiered access to view all are part of this record. So health agencies are not sharing health information. This is all the other demographics, household information, the other services in the community they're accessing, and in that yellow box are those risk ratings that I just talked about from that assessment tool. So it would enable all of the care providers in our community to access a whole picture of how all the community agencies are supporting that patient or that household, and help just really with their care planning. We can see what services they're receiving or not receiving. Right now we have our Ontario Health Team has a number of committees that are working on the various elements that we need for this longitudinal record to be created. So we'll be happy to share the learnings as we move along in defining those various elements for this data sharing. And I'm hoping Sarah Grace has arrived. Are you there, Sarah Grace?
Yes, thank you, Pam.
Okay. Over to you, Sarah Grace.
Good morning, everyone, and thank you so much for the opportunity to present today. As Pam mentioned, my name is Sarah Grace Bebenek, and I'm the project manager here for the South Georgian Bay Ontario Health Team, or OHT, which is one of 51 approved Ontario health teams in the province, working together as a collaborative team to plan and deliver a coordinated continuum of care for our attributed patients. And as you can see on the slide, our patients primarily live in the areas of Collingwood, Wasaga Beach, and Clearview. Our Ontario Health Team was developed based on a long-standing history and partnerships from across their community. And our formal community consultation to develop the Ontario Health Team began back in 2019. And since that time, continued consultation across our community with organizations, governors, patients, families, and caregivers has resulted in the development of our co-designed strategic framework for our OHT. Next slide, please. So based on consultation and community involvement to date, the following strategic framework that you can see here has been developed, as I mentioned, in co-design with our partners, governors, patients, families, caregivers, and those that live in the community. This framework informs our activities over the coming years, the principles by which we work together as an OHT, and essentially is our framework for implementation, measurement, evaluation, and funding allocation. The operational work conducted by our Ontario Health Team backbone support, led by myself and action teams, is guided by our implementation plan, connected back to our Ontario Health Team milestones, responsibilities, and building blocks. This plan has served and continues to serve as a foundational co-designed framework for our decision-making and project planning to advance our common goal and shared purpose across organizations for a healthier community. Importantly, including the physical, mental, and the social determinants of health. As you will see, one of the key priorities of our Ontario Health Team is digital health and innovation, which supports the development of innovative integrated systems to provide holistic access to care for our entire population. Next slide, please. As indicated in this diagram, as Pam mentioned, to execute our strategic priorities, the appropriate action teams have been developed using a shared accountability and distributed leadership model to foster authentic collaboration across our partners. The success of our teams to date can be attributed to our strong relationships with our community supporting agencies and organizations from across health and social care. Each of these teams has a specific terms of reference and work plan, which has been developed by the committee to implement and evaluate their work to continue to accomplish our framework's priorities, objectives, and to support our priority populations. The presentation today will focus, as you know, on the work of our Digital Health and Innovation Action Team and our collaborative project with Community Connection to integrate and connect health and social care. Next slide, please. So more specifically, the South Georgian Bay Digital Health and Innovation Plan aims to achieve the following objectives that you can see on the slide. With the presentation today really focusing on numbers 3, 4, and 5, specifically we'll outline how our collaborative project with Community Connection through the Ontario Health Team will ultimately better connect new and existing digital and virtual health systems and social services to enable data sharing and collaboration. It will deliver innovative and equitable population health-based solutions. and develop improved data collection methods to better understand our population's health needs and address health equity barriers. And ultimately, it will improve business intelligence and resource data to inform policies and programs within our Ontario Health Team. Next slide, please. So through the Ontario Health Team Digital Health and Innovation Action Team, the CIE project has decided to utilize the Ocean e-referral network through an investment that connects the provincial e-referral software with Community Connections SQL database. This connection will enable clinicians and community partners to make electronic referrals into Community Connection, or 211, either through a patient's chart or through the web portal. Through this process, patient referral information will be sent securely and electronically, and it can be linked with the patient's physician if selected and the patient provides consent. That way, the patient and the physician are continually updated about the status of their referral. So let me walk you through an example. So a referral can be sent through the Ocean e-referral by the patient's primary care provider or from a community organization such as the local YMCA. Once that referral is received by 211 through the electronic solution, the referral information is automatically translated into 211's referral and data system. 211 then contacts the patient based on the identified concerns by the initial referral and develops an outcome report based on that conversation with the patient including the resources that the patient is connected to. This outcome report is then sent back to the primary care provider if consent has been received, and that happens regardless if the referral came from them or came from the community. So they are notified of the patient's social determinants of health needs and really start to provide the wraparound services and care. And based on service trends, the 211 digital infrastructure can then evaluate gaps in available services in the area, which can then come back to the Ontario Health Team to inform our future program planning and development. Next slide, please. So just at a high overview, this slide outlines what it looks like on the e-referral software to initiate the referral into 211. So you can see here that the system has identified the local catchment area, and then we hope that through the Ontario Health Team model, we'll be able to spread and scale this project to serve all of Ontario. Next slide, please. Ultimately, the goal of the Community Information Exchange Collaborative is to improve access to 24/7 coordination and system navigation services and improve the health and wellness for individuals and populations through a holistic health equity focus. A focus of the work of our Ontario Health Team is to work together to reduce health inequities in the health system. And health equity is truly created when individuals have a fair opportunity to reach their fullest health and well-being potential, including the social determinants of health. There's many causes of health inequities related to the social and environmental factors, as you would be aware, including income, social status, race, gender, education, and physical environment, which we are working to address through the CIE collaborative. In South Georgian Bay, we plan to improve health equity through the Ontario Health Team by developing relationships with local groups, working on community safety and well-being, situation tables, and justice initiatives, and the homeless coordinated access systems. As a result of this collaborative community information exchange project, we can redesign care pathways for our most vulnerable population using a population health management approach, facilitate coordinated transitions and communication between providers, reduce inappropriate variation, and implement best practice standards for equitable access to services and provide services that better enable access, seamless transitions, and coordinated services. Next slide, please. So okay. I think, go ahead, Pam.
I'm sorry, Sarah Grace. Thank you so much for the presentation. And I'm not seeing yet any questions in the chat. So while we're waiting for that, I just want to say that we really appreciate the time that you've spent both today in coming to present to the group, but also the time that you've spent over the years in really developing out what this could look like for 211, but also for the people who make those connections to services. And We are continuously inspired by the work you're doing and always looking for how we can support, how Ontario 211 Services can support the expansion of these concepts into other Ontario communities. We do definitely envision, the development of the tools that are required to expand this work provincially, as well as, securing and enhancing the tools that we have today. So we really, truly appreciate your efforts, and we look forward to continuing to learn from the evaluations that are taking place of this work that you're doing.